Amy Alkon is the guest on my podcast today. She's an author and a scientific writer specialising in applied science. Her most recent book is Going Menopostal, and she's really unpicked a lot of the evidence. She's dispelling a lot of myths about the confusion between natural and synthetic hormones, and she really talks with a very personal experience as well. It's a really great book, and it's a brilliant conversation for you to listen to. So, Amy, I'm really excited to have you, even though you're over in US. But I've been reading your book the last few days, and I just love it. I love the way you think. I love the way you write. I love your inquisitive nature. So just before we talk too much about the book, just tell me a bit about you and why you even wrote this book.
Well, I have had the luck. I've been an applied behavioral science writer. So my writing, I give advice, but it's informed by science. And in 2007, I met Sandra Greenland, who's one of the top epidemiologists and biostatisticians in the world. And I was just desperate. I'm always desperate to be better at assessing research. And this guy is so generous. He coached me since 2007 in how to read and critically evaluate research. And he goes after methodological error and fraud and abuse in medicine. And so he sent me all these articles and papers about the horrible, horrible effects of care that is not based in good evidence. And because of that, when I have an issue at the doctor, I don't go to the doctor and say, like I with my hot flashes, I'm uncomfortable. What should I do? I go to the research base. I learn what the research says, and then I go to the doctor, and that is very protective. And this is why I wrote the book for other women, because most women can't do that. They're not these huge nerds. I read science day and night, and so we all deserve the evidence-based care that that you're a source of. You're my hero, and you're one of the few people in this area that I actually just fully respect.
Oh, thank you. And it's interesting because I'm like you, I'm very scientific. I love reading papers, quite meaty scientific papers, but I also really like evidence-based medicine, and medicine is an art and a science. I feel very strongly that the art form is individualizing care, but it has to be based on evidence. And many years ago, like 22 years ago, I wrote a book on evidence-based medicine for GPs, actually. It was called Hot Topics for the MRC-GP, and the MRC-GP is the membership of the Royal College of Physicians. So it's an exam that we take as GPs over here. But I realized that a lot of people are not quite so geeky as me. They have a better social life and they read other things. And so as busy doctors, you often read like the top line or the sort of highlights of guidelines, and you never read the papers. Whereas when I read the papers, I'm not just reading the science, I'm learning about the authors, what conflicts they might have, what other agenda they might have, who's paid them, is pharma behind them, like what sort of paper is it, and what are the numbers in the studies, and all sorts of things, which really builds up this picture. So I wrote the first book, and then I did 3 more books after, which were just like, first edition, second edition, so that when people were like treating someone with diabetes, I would be unpicking all the papers and just summarizing what they were. And I've always worked like that, and I really enjoy it, but I realize a lot of people don't. And it's not just the doctors. It's like you say, patients don't either. And then they go to a doctor. They don't know how much science they've read. They don't know how many papers they've read. They know they've got a medical qualification, but it's very difficult to know, isn't it? And so to have access to information as a patient is really crucially important.
In our training here, medical education in the US, it sounds like there's training in how to read and critically evaluate studies there. And I write about the 3 big myths in our medical care. And one is that doctors base your treatment according to evidence. And that's not true, because here in medical schools, it's more a moral failing. They do not teach doctors how to read and evaluate papers. So doctors don't read papers because they don't know how. And then, to be fair, at an HMO like mine, they see patients every 20 minutes. And so I might read at night. You're a nerd too, but people want to go home at night, and I can accept and understand that, as much as I think it is a moral failing for doctors to not educate themselves in the ways medical schools have failed them.
Yeah, and it's interesting. So I've worked 25 years ago when I trained as a GP. I was in hospital medicine before, and I worked full time, and I didn't have time to read many papers then. But then I worked part time as a GP, so I could be flexible around my children. But when I wasn't working as a GP, I was doing medical writing, so I was writing articles that was based on evidence for healthcare professionals, but also for people as well to learn more. So I've had a lot of blue sky thinking time. I've been really privileged with that. And then when I had my third child, I was only working 1 day a week as a GP, and it was really hard. Like, I'd come home after seeing maybe 60 patients, and I would literally, my children would know not to go near me on a Monday night. I was broken. But then the rest of the days, I would be reading articles and guidelines and papers, and then I would be summarizing them. And if you're writing about it, you have to know the evidence. You have to know it inside out, back to front. You can't write something unless you can support it by knowledge. And then I'd go back to the practice the following Monday, and I'd say, "Oh, hi guys, what have you been doing all week?" And they'd be just seeing patients. They would be having my Monday every single day. So of course they're not going to read. But medicine does advance and change, and things that I learned at medical school very different. The drugs that are available are very different now. I qualified 30 years ago, so things have changed. And some doctors just haven't advanced in the same way with their knowledge.
I have to tell you, you'll know how horrible this is better than anyone. The head of gynecology at the big, massive West LA facility had an appointment with me about 2 months ago because my gynecologist, who's great, is off. She told me the circa 2002 advice from the Discredited Women's Health Initiative study that I should taper off estrogen at 60 because it causes, and I'm 61, it causes breast cancer and Alzheimer's and all this. And I was so shocked. Here's this woman, she told me she read the science.
Mm.
Yeah, no, you haven't. You not only that, you haven't even read the practice bulletins from the Menopause Society from 2017, 2022 that say we don't have a stopping rule. We have what you said,
Mm.
individualized care, so important. We look at a woman's health and then monitor her, and that's why you can, if you initiate estrogen right at menopause or within 6 years, for cardiology, for cardiovascular health, you can take it throughout your lifetime if you remain healthy. And so you have it in your body protecting your bones at 79 when you're likely to fracture. And then you're not left for years from 60 to 80 without this while your bones, become more and more fragile.
I think what I'm going to ask you is really important based on your book as well. So I've got teenage children who are girls, and I've got an elderly mother, and my younger children can get hormones very easily. They can go and ask for contraception, whether they need it or not. They might just want it for their skin or their mood or whatever. They can go and ask it. And I can pretty much guarantee if they wanted it, they'd come out the same day with a prescription of hormones. My elderly mother has been on HRT for about 30 odd years now, maybe a bit longer. She has been phoned up by her GP last week to tell her she needs to stop it. Now, they're on different hormones. So the hormones of contraception are not the same as the hormones my mother's on.
Right.
So just tell me, with your knowledge and research, which hormones are safer?
Oh, okay. So transdermal estradiol, that's basically an estrogen sticker. That is the safest form of estrogen to take. And it, again, if you need to initiate it as close to menopause as possible. So menopause being 12 months without a period. And this is healthier than the oral estradiol, and you need less of it. So oral estradiol can do
Hmm.
all sorts of bad things like raising clotting factors because it goes straight to your liver. It's called first pass hepatic effect. That's fancy talk for it. You take it orally, goes to your liver. Your liver is very good at getting rid of stuff from your body. So you need a huge amount. And then transdermal estradiol, because it goes through your bloodstream, there's a negligible amount, trace amount that gets to your liver. And so it can't elevate those clotting factors. This is very important. And doctors don't know this. I know because one of the other substitute gynecologists just told me transdermal could cause me to have a heart attack or a stroke. And okay, that's physiologically implausible to impossible,
Yeah.
and the stroke thing, my blood pressure is 99 over 62. I'm not going to have a stroke. Okay. Let's look at our whole health. And this is something I appreciate that you do where doctors don't, looking at the patient as a system and being the creativity, the art of medicine you're talking about. You need to have the deep transdisciplinary knowledge to be able to look at what is the actual underlying effect. And of
Mm,
course, one of the other myths of medicine I bring out is that doctors are not trained in diagnostic reasoning. So this is a big problem because what they do is that you come in with a symptom. Now we're empathetic as humans, we evolved that way. And so the doctor wants to ease your suffering. Doctors are not terrible people. There's a sociopath in every profession, but they want to help you. They just don't know how. And so if you treat a patient the way doctors do with their unwarranted fear of hormones, give a patient antidepressants, and there are patients who need that, like, who can't take hormones. But if you give the patient antidepressants, what you're doing is leaving their breasts and uterus unprotected, their endometrium, their uterine lining, they're not being protected against cancer, breast cancer, uterine cancer. They're not having their bones helped. So you're treating the symptom of hot flashes, and the antidepressants do, but you're leaving so much of them not protected, not helped. And it's just terrible. And it comes out of the lack of science, in our medical care and the fact that our practice standards, they're not science-based and doctors don't know. And I want to bring out one
yeah.
thing because since you're the antithesis of this, um, in America, almost none of the gynecologists have any training whatsoever in menopause and perimenopause. They treat patients anyway, which is a violation of medical ethics. And then there are some experts, and they've been trained by the Menopause Society, and the training is a joke. 45 hours required of continuing medical ed in women's health in general, 15 of which must be in menopause and perimenopause. And then they take an online test. And then they're experts. They're absolutely not. And I know this because I'm like a medical lie detector for science. They say things to me in these appointments. I had ten gynecologists deny me the increased dose of estrogen I needed. And they just say all these things that are not scientific. And I have to not come off like the irritating know-it-all because that doesn't help you get the drug you need.
But it's very difficult. But also, like what I was trying to also tease out with my children, if they did, they don't. But if they did want contraceptive, then that's synthetic hormones. It's not even the same as my mother who takes body
Right.
identical. Estradiol, progesterone, testosterone are the same structure as the hormones we produce. Whereas in the book, you're very clear, especially talking about the synthetic progestins, but also ethinyl estradiol, conjugated equine estrogens, so the estrogens that have been used in older types of hormones, but they're still used in contraception. So I find it's like double standards. It's fine to have a contraceptive that's synthetic with risks, but people don't talk about those risks. They're younger people. Whereas any type of natural hormone, everyone always presumes has got risks associated with, even though they haven't. As many of you know, I'm passionate about helping women make positive changes for their long-term health and well-being. One of the things we often overlook is how important our feet are. They're our foundation. That's why I've been really impressed by Vivo Barefoot shoes. They're designed to let your feet move as nature intended, improving strength, balance, and connection to the ground beneath you. Vivo Barefoot are so confident you'll feel the difference that they offer a 100-day trial with a full money-back guarantee, so you can try them completely risk-free. And as a listener of this podcast, you get 20% off your first order with the code Newson20. Just head to vivobarefoot.com and give them a try. Your body will thank you.
The irony of this, and this is where the art of medicine comes in. So you have the deep transdisciplinary knowledge, and you see that this is ludicrous. I always tell women, that, I had the copper IUD, which is just copper blocking the little sperm from reaching the egg, and this is so important because, okay, there can be risks, perforation, everything, but those risks to me, if you look at the actual trade-offs, those risks are preferable to the risk of taking these synthetics. We talk about the Mirena mustache for women who have the Mirena IUD. There are all these viralizing, male side effects that can happen to you. And, why would you take something that has health risks when you can use the copper IUD that has no chemicals in it, that just has a reaction that kills the sperm?
Yeah, I think because people don't know, and often it's the patients don't know, but also the doctors haven't been educated the difference. And I didn't know for many years because no one sat down and spoke to me. And if you don't really know, you're not really understanding the difference in the chemistry. So I think this is where your book is so good and interesting, because it talks about the science, but weave through it. You've got your own personal journey as well. And we all change when we experience something. That's definitely for sure. Whether we're doctors or patients, we become more knowledgeable, and we also know how hard it is sometimes to access the medical system. So your book does a lot, but it must have taken you a long time to write the book and research, didn't it?
8-year deep dive. I did this thing you're
Wow.
not supposed to do as an author. I'm still living off my savings. I'm running out because this was such a mission. What had happened was I went to my healthcare provider, to my gynecologist, and I wanted to get oral micronized progesterone per the wonderful work of Geraldine Pryor, MD, the endocrinologist and clinician. And they, on the formulary, only had medroxyprogesterone acetate, the synthetic knockoff that raises your risk of breast cancer. It is harmful to the brain. It's harmful to the cardiovascular system. And so I fought 3 battles with a woman who's now the associate director of the hospital, former head of gynecology. They treated me with respect instead of blowing me off. They listened, and they allowed the progesterone, the dose I wanted, which they don't give in the US for no scientific reason, because we don't know how we metabolize steroid hormones. And so you need to make sure you have enough to protect your uterus and breasts against cancer. And it's also a very helpful, healthy drug that promotes GABA and sleep and mental wellness. And so this is not a drug where you're in danger. It goes up 10 times the amount in a menstrual cycle. In pregnancy, women are not dropping dead from progesterone, quite the contrary. And so when I did this, because I'm naive, I'm from the Midwest and we're kind of like Pollyannas. And I said, okay, so now I've showed you the science, and now will you put this on the formulary and give this to all women? I think there's almost a laugh. No, they wouldn't. And to me, this was like the equivalent of, I got the care. And it would be like watching a stream of women, an endless stream, walk into an open manhole and say nothing. And so I did this book. I call it the stupidest, most horrible, and most important thing I've ever done. Because my joke is that I forgot to take endocrinology when I forgot to go to med school. I had to learn all this. But I did this book as a mission because I thought, how dare you leave women unprotected when you know this? You've been trained by Sandra Greenland. You have the capacity to write this book in a way others don't. And I include all this stuff on dietary science and everything, the most efficient and powerful ways to eat and exercise, doable by mere mortals. And so I put this all together, but it was really, really horrible because you have to do what you're saying. You verify the science. What I love about you is that, you look at, the our people are this, who are the scientists? And I look at that. And what I see basically is that every scientist, the ones I respect, there's some way in which they're selling their point of view a little too unscientifically. And it depresses me, but I understand that we're human and people do this, but I look for it always in everybody. And I look for also big famous researchers. This woman, J. Julie Kim, not to call her up particularly, but she's famous. She has a paper on how progesterone causes breast cancer. And, what? Okay, wait a second. This doesn't make physiological sense. So I go and I read her paper, and I always look at the citations in the back. So the citations for this, they all say medroxyprogesterone acetate, and that's what those papers are about. And so this gets spread. It's like a game of toxic telephone. So when you get a prescription here for progesterone, you get this scary sheet with it. This is going to kill you. Here's how. Because it's for medroxyprogesterone acetate, not progesterone. That's how big the confusion is and how terrible it is.
Yeah, and it is confusing because if you use the word estrogen, it can include ethinyl estradiol, it can include equine estrogens and estradiol and estriol and estrone. So there's lots of different types of estrogen under the word estrogen. But the word progesterone is only progesterone. That's where we're really careful using the word. In the US, it's more progestins. We say progestogens, but it's not progesterone. And there is this big confusion. And like you say, Pryor's work is amazing because she has worked so hard for so many years. And I was reading the other day that she applied for so many universities. I think it was 9 times to try and get into medical
Right.
school as a
Yeah.
woman. And like her determination was huge, but she's still, people like raise their eyebrows and don't want to think about progesterone. So the WHO have got a list of essential medicines, and obviously there's antibiotics on there, there's really important drugs, there's insulin. But when you look at hormones, they only list the contraceptives and medroxyprogesterone. They don't have progesterone, they don't have estradiol, they certainly don't have testosterone. And, I think this is a real omission because it shows this sort of ignorance between these different hormones. And we've got to understand the difference because some are associated with risks, the synthetic ones. The natural hormones are associated with lots of benefits. And as you say in your book, the benefits to symptom control, but more importantly, the benefits to future health as well.
Exactly. And then another thing, in my book, I wrote the book and the longitudinal research was not out on testosterone. I now am taking it. I had to write my own prescription in the pharmacokinetics for somebody very high up in gynecology because they don't know this. They have the androgel on their
Mm,
formulary, and this men have 20 to 25% thicker skin, more sebum, and because I know how to take this, I have to take it twice a day, every 12 hours. I have to divide this, get in a little
mm.
container within 30 seconds because it evaporates, and I put it on with the back of it like an eye drop of the individual eye drop thing that I use, and then I mean,
It's
I'm not
madness.
getting an exact dose, and this is so terrible, and this is the how deep the lack of evidence in our medical care goes, where, they don't even know that you need to have cream, they should have cream in they're called oral syringes, which is they're not oral and you don't inject them, but it's a precise dose for women. Cream is better with women's skin, and I know because I've read your papers on testosterone. I was looking at one the other day when I was writing the pharmacokinetics up, and I mean, this is egregious. We don't even have form approved in here in America, and you have to have hypoactive sexual desire disorder. And by the way, before I did the medical stuff, I read the papers on this because I'm an evolutionary psychology expert. And it doesn't really seem to work for that. But you have to make up this story about your sad sex life in order to get it, because you have to look at what is it allowed to be prescribed for by the Menopause Society. And I'm not a dishonest person, but I'm going to lie for the benefit of my health if I have to get the prescriptions I need.
I have a real issue with HSDD, which is hypoactive sexual desire disorder, because it says that women have to be severely psychologically distressed for at least 6 months before being able to make that, have that diagnosis. Now, as a doctor, I don't let my patients become severely psychologically distressed with anything. So, and our guidelines and a lot of other guidelines say that if women have reduced sexual desire, we can consider testosterone, which is a lot nicer and it's a lot better. But it's not all just about having sex with a partner. So many of my patients are told by doctors, well, you haven't got a partner, therefore you don't need a libido, therefore you don't need testosterone. And I also think as a doctor, I shouldn't be judgmental. If people want to improve their libido, I'm not going to ask them like what they're doing with their improved sexual desire. It's up to them. And it feels really like going back in time to have these very rigid criteria to say whether someone can or cannot have a hormone that affects every cell in our body. It just seems
Yeah,
weird.
it's paternalistic to use that word. And the thing is, the real reason I wanted it, I have attention deficit disorder, which I hate. I don't have a deficit of attention. I have too much, all over the place, and I need to focus. Adderall helps me with that. But in menopause, you have a decrease in norepinephrine and dopamine, and these are some of the things that are
Mm,
already, not in
mm,
sufficient quantity in those of us who have this. And so in menopause, I had, really terrible memory problems, other problems, and estradiol helped. But the testosterone, I've just been taking it for maybe it's been 3 weeks. Oh my God, I'm back to being myself again. And I saw that and I had to make up this story about how, like, my sad sex life. And along the lines of what you said, I want to point something out too. Women, I have a whole section on vibrators in my book, that women, to tell women, it is wonderful. Give yourself pleasure, that if you have sort of stigma against that in your head, here's why you might rethink that, and to get the pleasure throughout your life that you can have, from the marvelous little we call it, you guys say clitoris here. Um, and this is stopping women from having the full rich lives they can. All this sort of prejudice against the drugs that comes from a lack of scientific evidence and fear. Defensive medicine, the practice of medicine to defend a doctor's license, avoid getting complaints, and prioritizing that over the patients. And the reason you have to do that is if you're ignorant. If you know the medicine, then you can confidently prescribe for your patient and let them know what the risks are, and the risks. If there are risks, that's real. That's doctoring how it should be, and it's not what we get for the most part.
Yeah, for sure. And actually, there's a lot of risks in a lot of other medicines that I prescribe as a doctor compared to hormones, and there's not nearly as much discussion out in the public about risks of antidepressants or risks of antibiotics or risk of blood pressure treatment. It's just maddening how it's been shoehorned into the space of
Yeah,
hormones.
absolutely.
So show me your book. I know you've got
Oh,
the book
yes, I
there.
should
Just
have
hold
done
it
that. I
up so
forgot.
I
I was
can
so
see
excited
it.
to be on. I forgot to sell my book. This is Going Menopostal: What You and Your Doctor Need to Know About the Real Science of Menopause and Perimenopause. And it's written in this everyday language because I needed to tell women the science without it being this medical ease where it's
Mm,
impenetrable. So what's been happening? This is so I have joy every time I get these messages. Women are going to their doctors and sometimes screenshotting science in the book and using it to get the evidence-based medicine where they're getting the hormones in a sufficient
yeah.
amount, the right kind. And that's just so beautiful. It's so beautiful.
I think it's giving people more confidence, actually, because your book is based on evidence as well as opinion. That's really important so people can learn from it. And you write in such an easy way for people to understand. So, um, I always ask for 3 take home tips, but what 3 reasons are there why people should buy your book? What are the 3 things you hope that people will learn and be able to act on from your book?
Well, I tell them, the actual science in contrast to what they prescribe here. I also tell you beyond hormones, because I'm transdisciplinary. I know there's evidence across many areas from decades since 1995 of reading and dietary science and exercise, the most powerful and efficient ways to exercise. And they are not based on nutrition research, which is the crap fest of research, where they ask you, did you have a donut? What did you eat last month? I can't tell you what I had yesterday. And so these are doable by mere mortals. I exercise, so you can see my muscles. I'm a lazy hedonistic pig. And so, I exercise 16 minutes a week with weights to get like this, and so you can do that. I have weights on my floor. I'm not going to go to a gym. Regular people, you get a gym membership, you don't go, then you feel bad because you didn't go, then you eat cookies because you feel bad. So we're not going to have that cycle. And then the other thing that I do in the book is to talk about aging at the very end and how women are stigmatized as we age and how ludicrous this is. We're powerhouses. I'm so much better as a human being at 61 than I ever was. And note that I talk about my age all the time. I will tell you my age as insistently as somebody who went to Harvard will let you know that before you've licked your martini olive at a cocktail party, because I don't accept the stigma. And if you're healthy, if you take the right hormones, use the right hormones, eat and exercise this way, protect your bones through eating and exercising this way, you can be old and be fabulous and have a new career and a new you. And menopause can be a beginning rather than a sad, oh, the change, and we're not going to talk about it. And that's why, by the way, my cover, I designed my cover and the title and everything. This is bold. It's like, we're not going to be all like ladies' bathroom colors here, the pink and the flower. No, 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 no. Broken fan. This is about the inexplicable rages women feel in perimenopause when they're not getting progesterone through cycles where they don't ovulate. And it's also about my outrage, the going menopostal, at women being denied the care. And so this is all about bold. See my earrings? They're like $2, but
Yep.
they're the size of coffee tables. I wear red lipstick. Here I am. I'm 61. I'm fabulous. You're not going to ignore me. And that's how I'd like to see women go out into the world because we're old and powerful and fabulous. And if you have your health, you're more able to do that than anybody.
Brilliant. What a great way to end. So thank you so much. It's been really enjoyable. Thank you.